rather than being separate and having these different conversations in two different spaces. And we really appreciate Bryce Gebhardt coming out here and representing ASPE and presenting this morning. And I'm really excited about what the future holds for the two organizations as we move forward to coordinate and collaborate.
Thank you. Good morning. Are y'all awake? Super. We'll see if I am. I'm really happy to be here today, and am excited about this affiliation that we have with SimGHOSTs. ASPE is the global network for human simulation education. It's kind of a mouthful. Currently, I'm serving as president on their board of directors, and so I'm here to tell you that we are eager to be a resource for you all. There are SPE educators around the world that have expertise in SPE methodology, and really, we absolutely love doing collaborative work. We love to share, we love to create new things, and we also love to have fun. I know that Dina Higbee is here with her team. They're the ones who brought the van that I think has been used for bug busters. I don't see Dina, maybe she was out there. Oh, there she is. So Dina is a very active ASPE member. Are there any other ASPE members here? Oh my gosh, yes. Yes, wonderful, wonderful. I am really going to speak very generally about SPE methodology this morning, so I will either hopefully grow your curiosity or help build your understanding about how the use of SPs can really enhance the benefits that we already know exist in simulation. I really don't have enough to talk about for an hour, or however long we're at right now. So please feel free to raise your hand and ask a question in the middle, but also we'll certainly have time for questions at the end. I guess my plants in the audience, like Dina and my colleague Stuart, can also jump in and ask questions if need be. I do have 3 disclosures that I need to make. You can decide for yourselves what's relevant. So first of all, I am an educator by trade. My second thing, which I've already mentioned, is that I'm currently serving as president of the board of directors for ASPE. And I know just enough to be pretty dangerous in the world of technology and IT. So bear with me. Let me tell you where I work. I work at Arkansas Children's in Little Rock, Arkansas. We opened our simulation program there about 10 years ago. We are a comprehensive pediatric-focused center. Really less than 10% of the curriculum that we participate in and facilitate is adult-focused. Our hospital does see adult patients, specifically in our burn unit. And of course, we sometimes have to respond to either adult visitors or even employees that need medical treatment. So we do some courses that focus on adult emergencies, but mostly we stay true to the mission of our hospital, which is to improve children's health, making them better today and healthier tomorrow. I can tell my CEO I said it publicly now. Our courses use all methodologies or modalities of simulation. So task trainers, low fidelity, high fidelity mannequins. We have a 3D printer, and one of our sim techs is constantly making sure there's something being printed and exploring new task training ideas with that. We also use SPs, or simulated patients, and sometimes they portray the patients themselves. Often they are family members, they might be healthcare workers, and we do a lot of crossover in terms of those modalities. So about 60% of what we do actually takes place in our center, which is a standalone building directly across the street from the main entrance to our hospital. The other 40% takes place in the hospital or on campus in our outpatient clinics, or even throughout the state. I'd say that 60% of our training focuses on our nursing staff. The other 40% of learners that we interact with come from in the form of medical students, residents, fellows, respiratory therapists, social workers, child life workers, the pastoral care team, our security department, the safety department, and then we do community outreach as well, and so we touch paramedics, EMTs, firefighters, community hospitalists and their teams, school nurses throughout the state, and then even high school programs. Again, because we focus so much on pediatric, we have a robust outreach program to help supplement and help people feel more comfortable responding to children, especially in emergency situations. The other thing that's going on there right now is that we're growing from a hospital into a system. We'll open a smaller satellite hospital about 150 miles away from the mothership in January of 2018. So currently I'm attending a lot of meetings that are focused on how we're going to onboard the staff and train them as we deal with that separation of the time and space. Quickly, outside of my work life, I'm the wife of a theatrical lighting designer. He's also a great dad and one of the most patient humans that I know. I'm a mom of an Eagle Scout who is kind of a techie guy, and a baseball playing fisherman who's 15 and definitely knows a lot more about everything than I do. I think that means that I'm a house mother in a fraternity house. Small thing in the back of my mind this morning is that my husband's returning from a trip from Germany, and here I am. And when my 15-year-old heard that we would both be gone at the same time, his first question was, "Can we have a party?" So here's hoping that my house is standing when I return. I do have a past life in the world of dance, and I still indulge in that a little bit, but not with nearly as much discipline or regularity. I'm very involved in ASPE, and as many folks in that world can confirm, I will sacrifice my dignity to lighten things up. Going as far as wearing a car and running around a big, huge conference room just to see if people are still awake. I often look to my dog who's there, Roxy, for inspiration in that regard. So, I know Lance asked the question about who here uses SPs. Let me ask a couple of other questions just so I can know where we're headed. Who here really, in terms of your background, is predominantly a simulation tech or has a strong background in the world of IT? It's good to know who you are. I might be needing your help any moment. Who directs a program? Any directors? How about, is there anyone here who really is focused and considers themselves in terms of the work they do predominantly an educator? Great. And I know we already had hands raised, but who's already working in any capacity with SPs? That is a bunch of y'all. I'm almost finished. You probably already know all this. Is there anyone who hasn't worked at all with SPs before? Great. So this is really, for me, basic, and I expect or suspect that for some of you it will also be basic, and so bear with me. Let me start with this quote from Meisner, as it really very much talks about how we use SPs in simulation education. Meisner was an American actor and acting teacher, and he developed an approach to acting instruction that is still known as the Meisner Technique. It's a catchy way to call it. The foundation of his approach really emphasized the reality of doing. However, although simulated or standardized patients are often called actors, and to be honest, sometimes when I'm talking to someone who doesn't know about them, I'll even say it's kind of like an actor. The reality is they're doing something different than that. And perhaps one of the best ways to begin making some distinctions about that is for us to start with this, which is a classic example of medical education using an SP. Perhaps some of you all will be familiar with this.
Hey, Jared, you got any pepper?
Hey, Jared.
Hey, Mickey, check the pepper shake? Yeah. Mickey. It sound like that, something like that. A little wetter. I didn't believe it. Well, what's with the fake sneezing? Yeah, we're going down to Mount Sinai Hospital. See, they hire actors to help the students practice diagnosing.
They assign you a specific disease and you act out the symptoms. It's an easy game.
Wow. Do medical schools actually do this? Well, the better ones.
In your package, you will find the disease you have been assigned and the symptoms you will need to exhibit.
Bacterial meningitis. Jackpot!
Gonorrhea. You want a tray?
Sorry, buddy. This is the hamlet of diseases. Severe pain, nausea, delusions. It's got everything.
Why don't you go on a tray?
Sure.
Okay, what do you got?
The surgeon left a sponge inside me.
Good luck with that. Well, I got gonorrhea.
That seems about right.
What's that game? It's for showmanship. Maybe that's what my gonorrhea is missing. Yes, step into that spotlight and belt that gonorrhea out to the back row. Yes, I will. I'm going to make people feel my gonorrhea and feel the gonorrhea themselves.
And are you experiencing any discomfort?
Just a little burning during urination.
Okay. Any other pain?
The haunting memories of lost love.
Lights.
Our eyes met across the crowded head store. I, a customer, she, a coquettish habitish. I pursued, and she a arrow, and she pursued, and I withdrew. And so we danced. And I burned for her. Much like the burning during urination that I would experience soon afterwards. Gonorrhea!
Well, that is definitely acting, and I would say it's not really simulated or standardized. So, although entertaining. So let's talk about what an SP is. If they're not an actor, then who are they and what skills do they have? An SP needs to be intelligent. They need to be a good, clear communicator. They need to be a quick and compliant learner. They need to be able to learn how to deliver appropriate and effective feedback. And they also need to be able to understand the role that they will portray in the context of medical education. A couple of things that are worth noting as well is that a good SP does not have a hidden agenda or happen to be on some crusade against the medical profession and healthcare in general. Speaking from experience, when you hire someone who finds an audience during feedback who has that vendetta that you don't realize they had, things go downhill quickly. One other piece is that an SP needs to be able to do the job on time as required and provide their own transportation. In other words, they need to be reliable. With those skills and characteristics, then they can be well trained and carefully coached in order to simulate a patient, a parent, a family member, or a healthcare professional. They'll be able to present the whole gestalt of the person they're portraying. Of course, they can simulate body language, emotions, mood, personality. They can bring to life the needs and expectations or even the fears of the person they're portraying, which brings us back to the Meisner quote, "They'll be able to live truthfully under those imaginary circumstances." Without really picking on actors, I want to make a couple of distinctions here. It's going to sound like I'm picking on actors. So, an actor is typically motivated by drama. They love it. An SP is motivated by being able to contribute. An actor is often ego-driven. It's all about them. An SP is education-driven. An actor wants feedback. How'd I do? Let's talk about me. Enough about me. What did you think about me? Very focused on self. An SP knows that rather than wanting that feedback, they are going to give useful, relevant feedback. An actor may be smart or not. As mentioned before, an SP does need to be intelligent. The other thing about actors is that they're very comfortable in the middle of an experiment. It gives them an opportunity to work on their craft. So they can do a scene and be irritated. I'm going to have the character be irritated. See how that goes, and then they'll think, well, now let me try to do it with a full rage, and it will be completely different. An SP actually strives to be consistent and finds actual satisfaction in hitting that mark in a consistent way. So, having said all that, actors sometimes make your best SPs. It really depends. It is especially true, though, when you're asking them to portray a role that will have a lot of emotion involved, and I'll talk more about that in a little bit. One other suggestion I would make, if at all possible, train your SPs for the job. So what I mean by this is often we rely on familiar staff or students or the admin person who doesn't need to answer the phone for 30 minutes, and we use them to fill roles. One of the problems with this is that it really discounts the real experience that we're trying to give to the learners, because they'll probably know who that person is. And if it's someone who is their faculty member, you're adding a different level in terms of, well, now can I really say that to them? I don't know, this is my teacher, so you can run into some problems. I'll be honest and say I think most of us, Dina, maybe not you, but most of us have probably done this in a pinch. Oh my gosh, I gotta have somebody be the mom. Hey, come here. But it's not best practice, and it can quickly devolve into a skit that's poorly executed, and therefore, as I say, undermine the outcomes of the simulation for the participants. Hey, if questions are arising, speak right up. Oh, good. Great. Okay, let me drill down a little bit more. We use the term SP to mean several things: standardized patient, simulated patient, simulated participant, some person, whatever. Sometimes we use an SP and we call them a confederate, and that might mean that they're portraying a member of the healthcare team. I have noticed that I hear the term simulated used more in Europe and standardized used more in North America. but mostly it seems like we in our industry really use those words interchangeably. And I think that this can be a little bit sloppy. So let me give you my experience in terms of what I think the difference is between the two. So a standardized patient is just that. They are consistently standardized to reveal the same case details based on predetermined questions or prompts, to give the same physical exam responses like pain level, to display the same level of emotion or mood, all to ensure that every learner has the same experience. Of course, the learners can change the experience because they are not scripted and trained in that way, but the SP's job in that circumstance is to stay as standardized as possible, speaking from the person they're portraying. A simulated person can be more flexible. Sometimes they're portraying a fictional character, if you will, or a patient, or they might just use themselves and their own history and go from that. They might have actual findings that will vary. Perhaps they have a heart arrhythmia that is not always present. Perhaps they have lung sounds that change, different kinds of or levels of wheezing, as an example. And that might change from learner to learner, and that might be okay depending on what kind of simulation is happening. They might use their personal history, especially if they're just allowing learners to practice interview skills. Simulated patients, I will say, also are more often used in hybrid simulations, but not exclusively. So let's talk about that. A hybrid encounter, from my perspective, means it's a marrying of some modalities. So you might have a task trainer alongside an SP, perhaps using an IV arm with an SP who is portraying someone who's afraid of needles. Or you might have a mannequin in an SP. Perhaps it is a birthing mannequin and the SP is bringing life to the woman in labor. Or you might do a sequential simulation combining modalities where a team responds to a code situation with a mannequin and then has to report back to the family about the outcome of that code or a medical error that happened in that code. That kind of simulation can also be executed with the family present bedside. So the presence of that SP completes a scenario. It does increase communication challenges for learners, whether it's just an individual or a whole team of learners. And it also actually increases the clinical challenges because of the balance of managing clinical needs and communication needs, the emotional needs, or just general information that needs to also happen for the client, the patient, the family. Sometimes people bring a family member to a doctor appointment. It certainly happens that we show up in emergency departments, usually with someone else. Those folks need to know what's going on as well. How do we practice that? From a pediatric perspective, I think this is worse in the summer, maybe because kids are out of school. But my experience is in our emergency department that I think people just it's almost like an ice cream truck. You drive through the neighborhood and say, hey, we're going to the emergency department. Does anybody want to go? Because the whole neighborhood's there with the patient. So what do we do with those people? Okay, a little bit of practical stuff now. For the faculty member or course director, it's not a given that an SP is needed. And in fact, there is no reason to add an SP to any kind of simulation unless the presence of that SP is going to enhance the learning and training experience. If it fits the competence level of the learner base, if it's going to complicate it too much and they're going to miss the part of clinical practice, because they're going to be so worried about this person, maybe it's not a good fit. So the litmus test often starts with the learning objectives, always. So they need to be clearly defined and point to what's the point of this teaching, this training, this scenario. Is one of those objectives to practice some kind of communication? Sounding good, that an SP might be an appropriate way to do that. So starting with those objectives, if there's an educational need to add an SP, then in the ideal world that we all live in, you get your SP educator involved. The person who is in charge of identifying, hiring, training those SPs. For lots of you all, I'm sure that might mean that you're the one who's doing it. No worries. So what you need with that, though, first is a truth-based case. I mean, Seinfeld is a great show, but typically that's not what we're doing, or Grey's Anatomy, as you well know. And so you're going to have to steer sometimes course directors away from that. I'm not really telling you anything you don't know. I always chuckle when someone says, okay, so we're going to do this code. It's going to be SVT. Yeah, we're going to do that. And let's see how they do. Oh, can a nurse like faint in the middle of it? Can you like get someone to just faint? Sure, absolutely we can. Can you tell me what learning objective that's going to help meet? Well, I just think it'll be fun. Okay, that's a beep for me. How about, can the patient like just absolutely, since we're just having these nurses practice TB skin tests, what if we just say the patient refuses? Okay, we can do that, absolutely. Now, will that meet your objectives? Are you wanting them to practice that? Or do you want them to practice someone who doesn't want to have that TB skin test taken? Either one is okay, but what are your objectives? So, the questions that will be asked about the SP and who they are to be might seem a little irrelevant or crazy. So, what's their mood going to be? How should they be dressed? I'm going to hire this fly. It's going to be an SP. What's their home situation? That makes the SP be able to portray someone who's three-dimensional, real, and engaging. So, what can an SP do? They can give information, help move the scenario along. Ow, that hurts. Oh. Or, you know, he's really looking terrible. Can you get a doctor in here? I'm concerned. So those specific questions or comments can drive the learners, again, back to specific issues that are going to hit the training objectives. They can, as I mentioned, reproduce history and physical findings accurately, multiple times. And they can give feedback. It can be written, it can be verbal, it can be, depending on, again, the curriculum, during the encounter or after the encounter. Perhaps stating the obvious, an SP cannot submit to surgery or agree to have invasive medical procedures done for the sake of practicing. So an SP is not going to say, sure, go ahead and place that IV, no problem. Or, yeah, go ahead, innovate me, it's fine, no. Or, yes, let's try defibrillation, no. They also cannot make a clinical judgment about medicine or interpret clinical data, even if they personally have a clinical background. We can have a conversation about this, but from my perspective, this begins to muddy the water for the course director or the faculty member who is the main facilitator. And it can also muddy the water for the learners. In addition, an SP who has some knowledge base can all of a sudden start to become an expert in their mind about what the standard of practice is for this clinical situation. And then the faculty member has to undo that because perhaps that's not true. Best to keep them focused on communication. How are we doing? We're going to have plenty of time for snacks. Do y'all have lots of, oh yeah, plenty of time. So let's hold on. Where's that one? Let's do, here it is, a little bit more about the basics of coaching the SP. Again, broken record here, you need the case objectives. And they will help you decide, is this SP going to be standardized or are they going to be simulated? Once you get your SP, you want to, first of all, speak in layman terms. Avoid the jargon. A course director will sometimes use lots of medical jargon as they write out the case. You need to interpret that so the SP understands it. They need to be able to get that information and begin to understand how they'll meet those case objectives. You might consider teaching the case in segments or in multiple trainings, again, depending on how complicated the case is and if they really need to be very standardized. Another training point is that if you're going to train multiple SPs to portray the same person, it's very helpful to do that in a group with them, because then you're not just standardizing one person, you're able to get all of them on the same page. So show me what you think level 4 pain looks like if on your face. Or let's find a common ground so that no matter what, everyone that interacts with each of you will get the same experience. Don't forget, in a hybrid scenario, to get them familiar with what's going to be in the room with them. Orient them ahead of time to the mannequin or the task trainer. Some of the mannequins look a little scary to SPs. I know when I started this work 10 or so years ago, the first time I walked by one of our mannequins and I was kind of away and he happened to be breathing, I was, oh, what's that man doing there? So an SP may not have been around a mannequin and might think, oh, this is a little creepy. We obviously have a lot of kids that come in and out of our center, and to be honest with you, I try to keep them away from the mannequins. I don't want to be responsible for their parents losing sleep at night because of nightmares. So plan ahead, orient them so that they get used to that. You can go ahead and make sure that they have a very basic working familiarity of the mannequin or the task trainer, because they might, with your training, be able to determine if it is functioning correctly, especially if you're going to do multiple encounters. You can train an SP to start a mannequin or a task trainer to check the settings. But again, you don't want to be doing that as the learners are walking in and ready to begin. That happens beforehand. So that would point to best practice again in terms of doing a final run through, a dry run, however many times it takes for them to get comfortable, to confirm that they're going to be able to help move us towards those objectives. The training takes time. It's absolutely worth it. One thing to keep in mind is that once you spend that time training an SP and getting them up to speed and they've fine-tuned their work, let them do that as often as they can. Let them do that case, because it helps keep it familiar to them, and you'll have to do less triage with, oh, no, 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 no. Remember the last time we did this 6 months ago? Your pain level's only a 2. You just said 7. Yeah. So the more often they can do it, that helps. All right. This was the slide I was looking for. I'm back to Roxy. Sorry, she really makes me laugh. So in terms of taking care of these SPs once you have them, this is project-driven work, and so the kinds of folks that do this need to feel engaged and feel like they're making a contribution, and that takes a bit of care and feeding, really. So keep them educated, keep them in the loop, let them understand the importance of the part that they're contributing to the simulation, to the curriculum. Make sure they understand the process. You always want to include them in a debriefing session, either with the learners or even just with other SPs, or if it's just one SP by themselves. I'm serious about feeding them, really, especially if they're working for more than 4 hours or over a typical meal time. And if you happen to use children, and we do, I would plan for snacks no matter the length of time that they'll be there. At least have them available even if they're not out. However, it is important to offer healthy snacks. Nobody really wants a jacked up kiddo who's had a candy bar and a Coke trying to do good SP work. And even, I find that I use a lot of homeschool families to find folks that will do that. And it's interesting because a lot of times those parents are really very thoughtful and particular about the kinds of foods that their children will eat. And so if you happen to have Cokes, those kids, it's like they're jonesing for something that's not granola. So, maybe juice, maybe stay healthy. I want to backtrack to the kind of really emotional work that sometimes SPs are used for, either by themselves, someone who is going to be told that they have a life-changing diagnosis, or as a family member. For those people, it's really important to pay attention and absolutely debrief them at the end. You have to pay attention to their capacity, their emotional capacity, especially if it's someone that you're using that you haven't used before and so you don't really know. Again, that's why we do training sessions and dry runs to start to see if how they're managing. You also have to pay attention to how many times in a particular day they're going to do that kind of work. Less is more, really. I want to backtrack then to actors, because often actors are good candidates for this kind of work if they can be reliable with the coaching you give them and they don't decide to do, as I said, well, a little irritated one time and completely enraged the next. But if you can get them to a level and they will hold that level, then they also, just because of their training, have the capacity to enter into that emotional state and come back out of it with a bit more skill. People that aren't trained actors certainly can do this as well, but I do find that for very emotional things, sometimes it's helpful if they've had at least a little bit of work in that field. For the SPs that are doing that really deep emotional work, chocolate, chocolate, chocolate. Keep it on hand. And help them transition out of that. So ask them to bring a different set of clothes, or suggest that when they go home they take off what they've been working in and put something else on. Go exercise, take a shower, sing loudly, watch a comedy. Don't isolate. We want to do, again, what we can so that they put their work aside and move back into their lives. If there's someone that's new or you're not sure about them, it's a really great idea to check in with them within the next 24 hours. How are you doing? That seemed kind of rough yesterday. I'll tell a story. When we first opened 10 years ago, we were using a lot of SPs that the medical school about a mile away had been using for some years. And there was a woman doing all sorts of SP work there. So she came to our center, and we were going to do a code situation for brand new residents. And we're using a mannequin as the patient, and we trained her well. We said, you're going to be a bit of a distraction. We want you to be hysterical, actually. We want you to be by the bed. We want you to be in the way. We want you to make them have to move you. So that was one of the actions we were looking for. And if they ask you if you want to step out or say to you that you need to step out, we want you to agree. That will cause you to de-escalate and be removed. We started the scenario. They never asked her. She was laying on the bed. They weren't looking at her. Now, clinically, they managed with a bit of shell shock to take the right actions, and the child was fine. We went through the debriefing. She offered some very good observations from the perspective of the mother, talked about how she was overwhelmed and really was looking for someone to pay attention to her enough, because she actually wanted to leave and didn't know that she could, and it was great information for the learners to have. And then we debriefed her, and she said, I really appreciate that you asked me to do this work, and I know it's important. I can't do this. She was a mom in real life. So she said, I can have a brain tumor all day long, but I can't go to that place where I need to be authentic and have a child that I am saying is mine there with no heartbeat. I can't do it. It's too upsetting. And so that was great. We talked her through more of that, and it was great information to have. And it informed how we started using SPs and paying attention differently for those kinds of scenarios. One more little bit of information. So we use both written and verbal feedback with SPs. In order for their feedback to be additive to the simulation experience, the following things need to be true. The feedback needs to be honest. Otherwise, it's not valuable. It needs to be specific, with the SP citing examples from that encounter to support their observation or their feeling. It needs to be non-judgmental. And by this, I mean it doesn't need to just say, the feedback doesn't need to be, that was good. Or, I didn't like that, that was bad. It instead needs to describe the experience of the person that's being portrayed. That said, it's fine for both favorable and not so favorable observations to be made, and they should be included with a balanced, constructive approach. The SP needs to make sure they're citing behavior in the learner or learners that links to the feelings and experience that they had as that patient or the person they're being portrayed, that they have portrayed. So, as is true beforehand, training the SPs about how to give appropriate feedback and allowing them to practice that is really important. As mentioned with the vendetta against the medical profession, your debriefing can really get hijacked if that's what kind of feedback starts to happen from the SP. And if the SP doesn't know the case objectives, it might be more challenging for them to provide specific feedback that, again, helps the faculty member, the course director, hone in on those objectives. So it takes time and it's worth it. With apologies to my cat who didn't get a lot of airtime, she's not as funny. I'll say I really have just skimmed the surface here this morning about some of the important parts of SP methodology. I hope I didn't oversimplify or spread it all out so much that it became irrelevant or not useful. With a bit of luck, maybe I've created some curiosity or an interest in adding SPs or an interest in taking your work with SPs to a different level. If you're really feeling hungry and adventurous and you like to travel, I would love for you to join me in Singapore in November. ASPE will be doing a conference in there. It actually is butted right up next to the IMSH Singapore conference, so you could kill two birds with one stone, and you could just get completely baptized in the adventure of SP methodology. So, any questions? Yes?
Question on using the children. How do you go about employing them and kind of the logistics of that?
How do you go about employing children and the logistics of that? Different institutions handle it different ways. So I will tell you what we do. Dina, if you want to add to this, feel free. We don't employ children. I also don't use children much under the age of 8 or 9. A lot of times mothers will be, oh, they're in the plays at the theater down there and it's great, and they're so extroverted, and then you get them one-on-one with a medical student or whomever and they won't make eye contact, and so, or they act as if they're coachable and then they're not really reliable and they just blurt out all sorts of information that they should be waiting to be asked about or is irrelevant. So, so I don't use super young children. And when I use children in the 8 to 12, 13, 14 range, I hire their parents and expect that their parents will be there and be part of the process. Once they hit 15, 16, really, from a legal standpoint, then I can hire the teenagers themselves. When we hire folks, they're contract labor, and so we don't have to work them through HR the same way we would if they were really employees of our hospital. I've had very candid conversations with the labor board in our state, and they know I'm skirting the edge, and they don't really care because they have way more important fires to put out. So, is there anything, Dina, from your perspective you'd add, or?
We also hire the parents for the kids, but we also have a lot of positions of nurses will bring their kids in to work with the courses all the kids.
So in case you didn't hear that, they also sometimes will use their staff, physicians or nurses, and let those children come in and do the work. And then it's on a volunteer basis. And we have also done that. Other questions? Yes?
I just want to tag along with that legal consideration.
Mm-hmm.
I don't know anything about the logistics as well. And if I'm hesitant to dive in because it would be me, and I'm not sure how to speak at all.
In terms of children, you mean?
No, in general, adults. Just, is there legal, like, do they carry a policy? Do you get legal involved to start the program?
It is, so, I'll speak to my experience. It really is almost institution by institution driven because people handle it differently. We did involve legal, and they helped draw up a contract. So, and our fiscal year starts in July, so every June, all of our SPs that are pretty regular, we start having them fill out an annual contract that states the range of pay because we pay different amounts for different kinds of work. They sign it, I sign it, it lasts until June 30th of the next year. So legal did that contract for us. In terms of children, I haven't really talked to our legal department about that. We're not going to put this on the web or anything, are we? I mean, they sort of know, but what they know is we're hiring parents.
Any liability though in the contract? Liability concerns or it's just
No, it's a pretty standard. Now, if they get hurt while they're working for us, yes, they're going to end up going through our system. Dina.
if you're able to hire them as a part-time employee, then all of your university structure will cover that employee. So like ours is 0.03 FTE, something on an absolute basis. So workman's comp, all of that covers our employees.
Did y'all hear that over there? So if you're able to hire them as a part-time employee, and she said hers are all 0.03 part-time on an as-needed basis, then the structures that are provided for your institution's part-time employees might cover some of those considerations. Is that an okay summary? Yes?
Use SPs for assessment, particularly high stakes assessment of students or trainees.
Absolutely. So, and I didn't really talk about that a lot because at my institution, because we really are a pediatric hospital, we're loosely affiliated with the medical school that's down the road. We only do one test, which I think is unusual in the world of simulation, at least in North America, where we really only provide one testing situation for third-year medical students for their pediatrics clerkship and ASPE. And that is a complete SP-driven test. The cases that they do are all just, in terms of simulation, just with SPs. Those are the kind of scenarios that take a lot more training, that take a lot more specificity in terms of what are the prompts, what are the questions that you might be asked that would allow you to elicit this information. There might be in a case a challenge question that the SP knows they need to ask before the time limit is up if the student doesn't bring that up. And then there are checklists that are involved, of course, with SPs that have been trained observing in another room. For the clinical checklist, which might be, did they ask when the headache started? Did they ask, is anyone else in the household sick? Did they ask? So it's very clear. You don't need a lot of clinical knowledge as an SP to grade that, because they're yes, no questions, and really what you need are listening skills. One of those checklist items might be, did the learner listen in 4 places on the back for lung sounds? And that would take some training as well. This is what we're looking for specifically. So you can use SPs to do that, to grade, and then another one to be in the room so that the grader's watching. And the person in the room then also fills out a grade that's based on communication. So.
All right, let's thank Grace with a round of applause. Thank you so much, guys. We really
You're
appreciate
welcome.
it. So we're really excited, obviously, about this new affiliation, which